Thank you all for joining the HIV, AIDS, and substance abuse. What are the connections and implications for treatment provision webinar? This is being presented by Robert Charles Wright, who was the director of the New York Region Training Center for Phoenix House for 8 years, where he managed the implementation of clinical staff development, curriculum, and program initiatives. He brings over 20 years of experience as a direct service practitioner serving populations with substance abuse, mental health, child welfare, and HIV/AIDS. These practical experiences inform and influence his ability to deliver trainings that are enhanced as a result. Robert believes that knowledge is power and that the best decisions in our personal and professional lives are those that are informed decisions. He receives great satisfaction from being an educator and is currently an adjunct professor at Monroe College, Lehman College, and the College of New Rochelle in New York. In addition, Robert is the president of the RCW consultant firm and continues to be a clinical consultant trainer for nonprofit organizations such as the Minority Task Force on AIDS, the Children's AIDS Society, the Northeast ATTC, and the Federation of Protestant Welfare Agencies, providing lectures on diverse topics. If you would like more information on other upcoming webinars, we have our link there at the bottom. Now, again, this webinar is being recorded and will be available for download, on-demand viewing on our website later today. Okay, at this time, I'm going to turn the presentation over to Robert Wright, and he will start his slide presentation. Okay, Robert, just click on that box in the middle. Okay, Robert, we have you unmuted. Can we hear you?
I can hear you. Can you hear me?
It's really, really faint.
Oh, okay. About now?
Yeah, I can. If a couple people want to reply to see if they can hear you, okay? It still is a lot fainter than what it was earlier today.
Really?
Yeah.
Ah, I'm actually using the same phone. It's right here next to me. It's on speaker. Let me take it off speaker and put it back on.
Okay.
How's that?
Yes, much better. Thank you.
Okay, maybe it was just with the low.
Okay. Yeah, so you can just minimize the download complete screen that you have there, and yeah, and then pull up your slides.
Here we go.
Good. Thank you.
You're welcome. Okay, are we ready to begin?
Yes, thanks.
All right, I also want to welcome everyone who is joining the webinar today. And I guess we'll just get started with the learning objectives for this afternoon's webinar. So our first objective is to identify the social and psychological aspects of HIV infection that may impact alcohol and other drug treatment outcomes. And I think my experience has been in the field is that much of the education around HIV is directed more towards the medical than the social and psychological. And although the medical is extremely important, I think our role as clinicians is to really focus on and help the client negotiate the social and psychological aspects of being infected with HIV. Our next learning objective will be to discuss the experiences of special populations relating to the stigma and discrimination as they relate to service delivery. And so we'll be looking at adolescents, older adults, the LGBT population, and women during the course of the webinar. And finally, to describe practical strategies that will support the HIV-positive client in achieving his or her treatment goals. So those are our kind of learning objectives today, and I'm sure as we're going through this, some additional stuff will come up, and hopefully we'll all gain some new insights. So I'd like to start off by defining HIV/AIDS. Naturally, those are acronyms, the letters, and the first one is HIV, human immunodeficiency virus, and then AIDS, acquired immune deficiency syndrome. And HIV/AIDS actually compromises the body's natural immunity to fight diseases. That's the function. I always relate our immune system to the sanitation department in our bodies. So can we pull up the polling question number 1, Christine?
Sure, just a second.
Mm-hmm.
Okay, we just launched the poll. Individuals who are HIV positive have a moral and or legal obligation to tell their sex partners of their status. So if people would just click on the answer, whether they agree or disagree, we will see those totals come up and then be able to discuss the answers. I'm just looking, everybody's in agreement here.
Wow.
Okay. Well, now we're hearing from the opposition. Just a second. I'll be closing this in just a minute since people are very quick. Thank you. Very quick in responding. Okay. I'm going to close this poll now. Looks like we have a good representation, and I'll share the results. Okay, Robert, individuals who are HIV positive and have a moral and or legal obligation to tell their sex partners of their status, 97% agree with that, and 3% do not.
Okay, so I'd like to just take a moment to share my thoughts about the responses. I think oftentimes when we respond to this question, we're responding, the human being in us is responding to the question, especially when we factor in the word moral, right? Because morality is about what's doing what we believe is right as human beings. And legally, you know, in terms of the law around that, it's hard to kind of enforce that, if you will. To determine, and there have been several cases, as I'm sure most of us know, where there have been convictions about people who knew their status and then infected other people, but it is a difficult legal, I think, issue. I think, though, as clinicians, one of the things that we might want to do is take our moral cap off and really look at what might be some of the issues that would prevent one of our clients or patients from revealing their HIV status, and to sort of help them process what their specific fears are about doing so, because as we know, there definitely is still a stigma connected to someone who is living with HIV and AIDS. So I think this is one of those questions that is open for discussion. And it depends on what perspective we're coming from, but I feel as a clinician, my role is to help the patient sort of determine that or develop the skills and strengths needed to share that information. I'm not sure whether I would approach it from a moral or legal obligation. I try to connect it to recovery and being honest and the need to protect oneself and protect one's sexual partners. All right? So we'll move on.
Yes, move on, please. There's no questions yet.
All right, great. For some reason, just give me one moment. For some reason, I don't know if the system is frozen. Let me see.
Robert, if you go to the very bottom of your slide, the very bottom corner, you should see some little icons. Yeah, I think the bar might be holding it. Just use your computer arrows to move to the next slide.
Yeah, I'm trying to do that, and it won't. It's not moving.
Well, minimize.
Chris, this is Holly. Chris, can you hear me? This is Holly.
Yes, thanks.
Hello? Yeah.
Yes.
Robert, where you were going to the bottom left, you can, if there's white arrows, you just have to mouse over them very lightly, and you'll see one to advance it to the right. Keep going up a little. You should be able to, and that will activate it so you can go. It's on the PowerPoint slide itself, and it right around the, do you see the arrow? There you go. Keep going over. No. Go over one more. Robert, if you go over one more icon, there'll be an arrow.
I got you.
No, go over to the right. There you go.
Okay, great. Oh, sorry about that. Technical difficulty.
Yeah, no problem at all. Thanks.
Okay, thank you. All right, so let's look at some of the history and statistical data. As most of you know, the first cases that we saw in the United States happened in the early 1980s. And this is our 32nd year of dealing with HIV and AIDS. I would like to pose this question, who was the president at the time and what was his political position? So I'll just go ahead and share that it was Ronald Reagan. And unfortunately, it was an interesting time in politics where the president came on and made some statements that actually ended up being a little misleading. His approach was, well, if you're not an IV drug user and you're not an openly gay person and you're not a Haitian, interestingly enough, because at that time there were a large number of Haitian immigrants being held at Guantanamo Bay, that you didn't have to be concerned about becoming infected with HIV. Those were the early populations that the disease was identified with. And unfortunately, we know today, well, fortunately, we know today that that's not the case, that HIV/AIDS is a disease of the behaviors, and people who engage in high-risk behaviors can contract the disease. The Center for Disease Control, the CDC, which is in Atlanta, Georgia, tracks and provides infection rate data. One of the issues about this data is that it's usually not current, meaning that we're always 1 or 2 years behind with the data from the CDC, naturally because of the process of just collecting that data. So whenever you see statistical information, like in the next prompt, in terms of the number of cases in the United States, we know that those numbers are conservative simply because some people are infected with HIV and don't know their status, so they would not be included in these numbers. So these are the numbers that we have definite information on in terms of infection rates. And as you can see, 32% are among people who have a substance abuse disorder. So it's a little less than half of the cases in the United States are definitely, there's a correlation between substance use disorder and HIV infection. All right, let's continue with the historical and statistical data in specific cultural groups. There's actually been a decrease in cases in the population and communities first identified with the disease. Specifically, IV drug use accounts for 8% today. We've also seen a lower rate among gay men as well as a result of the mobilization and grassroots organizations as in New York City, such as the Gay Men's Health Crisis. That community started to mobilize because it was one of the hardest hit communities in the early days of the disease. We see higher infection rates among women of color, ages 15 to 45, which, as you know, that age group is childbearing age. There's also a steady increase since 2008 in infection rate among senior citizens, which we'll be talking about later in the special populations component of the presentation. MSM, which stands for men who have sex with other men, accounts for 61% of new cases in 2010. And heterosexual contact, 28% of the new cases in that same time period.
Cool. Scary, but cool.
Hello? Okay. All right. HIV and AIDS today, we definitely have moved from an epidemic to a pandemic. As you know, epidemics are usually more localized or centrally located, and pandemic means worldwide. So today, there are cases of HIV/AIDS throughout the world. There's a shift in the view of the disease to a chronic illness like diabetes versus what we see in the next prompt as someone living with HIV versus HIV, AIDS, and then death. In the early days of the disease, we did see a lot of people dying rather quickly. Today, the view is, thanks to the medication protocol, the cocktail concept, which is a combination of medications, people are living longer with HIV and AIDS. So that sort of formula of HIV equals AIDS equals death, we should have a different perception about that today in the field because HIV is a manageable disease without a cure. Education and prevention efforts have definitely increased. There's lots of information in organizations, so it's readily available to people. It definitely has a cultural component to it now. You see HIV and AIDS literature in several languages. And so they're reaching more people with the information about transmission and how the disease is spread. And finally, again, one of the things that I always say is that HIV/AIDS is a disease of the behaviors. It doesn't matter what your economic status is, what your ethnicity or race or culture is. This is a disease that is contracted through high-risk behaviors. Okay, so Christine, it looks like we're ready for polling question number 2.
Okay. Okay, I just launched that poll. How can we best address a patient's strong conviction of conspiracy theories about HIV? Do we dismiss it as silly and give them the facts as we know them? Do we respect their views and beliefs and provide the factual information? Or do we act like we didn't hear and then just give them the facts? So if you can, please vote on that. And Robert, while people are voting, I have one question here, is how do we not disclose the condition yet help the client in need?
I'm not sure if I understand the question. How do we not disclose the client's status?
Yeah, it's concerning confidentiality. How do we keep confidentiality and yet help the person in need?
Well, I'm trying to think of an example where you would need to, the laws of confidentiality are clear. We cannot give any information about a patient without their permission. One of the examples that I'm thinking of is an incident in a residential program where you have an HIV positive resident that sexually acts out with a resident whose status we don't know. And so the chances are, in that instance, that that patient, that resident may have contracted the virus through that sexual encounter in treatment. Legally, and in terms of confidentiality, we would not be able to tell the residents whose status we don't know about the person's status that they sexually acted out with, because we have a legal obligation to maintain that person's confidentiality. So the issue becomes the breaking of the rule of no sexual acting out in treatment, and then kind of figuring out, different states have different laws about this, but figuring out how we may encourage the patient to get tested. Because the other issue is we found the alarm, we put the person who is HIV positive at risk, one, and it may turn out that that person was already infected. And so we're blaming or saying that the person got infected through the sexual contact with the patient that they sexually acted out with, when in fact they were already infected. So those are the kind of ethical, I think, dilemmas that can come up in terms of confidentiality. But not sharing a patient's status should not impede our ability to help them or to encourage them to share their status if the question is with a mate. And there is a law in New York State called partner notification, where a physician is the only person who can, in fact, share that information with the significant other of a patient. But as clinicians in substance abuse treatment, we would have to encourage the patient to do that. And I would encourage not to judge them based on their resistance or inability to do that.
Okay, thank you. So that answers the one question. Now, let's see, for our poll, I'm going to close this, and once again, everybody is in total agreement on this one. We have 100% of the people who replied saying that they would respect the client's views and beliefs, but they would also provide factual information to that client.
That's great. That is absolutely great, because I think it is extremely important that culturally there may be some belief systems, and in the United States often veterans are famous for having some conspiracy beliefs about what the government is capable of doing. And I think one glaring case of that is Tuskegee experiment. A certain number of men in the South had syphilis and were not treated. And so, certain cultures are suspicious of the medical of treatment and of access to treatment, and so that does impact their views, and sometimes it's kind of well founded. You can almost understand why they might have a conspiracy view. I've heard patients say that HIV is a man-made disease and it got out, and there are two scientists somewhere in a bunker with a bullet in their head, and that we as a nation knew about it and maybe planned to use it for chemical warfare. So I wouldn't discount that. I would acknowledge that I'm glad that everybody was on board with kind of respecting someone's views, especially if they're cultural views, and then giving them the facts as we know them today. So that's a great acknowledgement of that question.
Okay, I think that's it for the questions for right now. If there's any more that come in, we will do that during the next poll.
Okay, great.
Thank you.
All right, so let's look at routes of transmission. The first one is unprotected sex, sharing needles, blood transfusions, although that happens less today because we do test the blood, and perinatal mother-to-child. I would just like to say a little bit about the perinatal process. And in uterine, a mother who's actually HIV positive, the child may not be infected in utero, but during the actual birth, the birthing process, that can be extremely traumatic, and there may be, the baby may come in contact, or the new infant may come in contact with blood during the birthing process, in the birthing canal. And so that also can be a route of transmission, but the baby could have been negative in utero. One of the other options, or ways that the disease might be transmitted from a mother to a child, is that a baby may be taken home who's not HIV positive, because there was no transmission from the first two options, but then the mother who's HIV positive breastfeeds that child. And we do know that when we look at the body fluid, the HIV virus does exist in breast milk. So there have been incidents where a mother took a healthy child home, breastfed, not realizing that that would be a way to affect the child. And then when the child was brought back to the hospital, it's determined that the child was also HIV positive, and got the transmission was through breastfeeding. So when we look at body fluids, we're talking about blood as number one, semen, vaginal fluid, breast milk, and other body fluids that may contain blood. To date, what we know is not found in feces, tears, perspiration, urine, or saliva. All right, let's move on to the social aspects. There continues to be a stigma attached to people living with HIV and AIDS. Although people are living longer, and despite the knowledge and education about the disease that's out there, there's still what I would call AIDS phobia, or HIV/AIDS phobia, that there are people who still make inappropriate comments about someone with HIV, or just not knowledgeable about the transmission of the disease. There's still societal and public stigma in terms of services, employment. Again, there's less of it, but it still does exist. Healthcare and addiction professionals may have a negative attitude towards homosexuality and injection drug users. That still exists. And that's what, as a professional, we need to be able to have the ability to do what I call the art of separation. Regardless of how we may feel about these populations personally in our personal lives, if we're going to be providing effective services for them, we do have to, I guess, seek supervision or other help if we have those types of issues. Some make judgments about the lifestyles of these two groups, and therefore feel like they deserve to have the disease. That's still a mindset prevalent in the field, not only in our society, but, you know, people, healthcare professionals, clinicians are part of the greater society. And we're all diverse, and we have our own belief systems, and so that can sometimes seep into our interaction with these populations. Social aspects continue. The person who's living with HIV and AIDS might be isolated from their family, friends, and community as a result of that stigma. I was an adoption home finder for many years for children who either lost both their parents to the disease or one of their parents. And family members, the sister of the mother who died, these were their nieces and nephews, would not adopt those children, would not even be the foster parent, simply because the parent died of the disease. And so, again, that's connected to the stigma. And in many of those cases, I would counsel them, give them information, and they would be concerned that somehow the child would either infect them or their children. Many people with HIV and AIDS are social outcasts, and that can worsen the traumatic experience of being infected, especially early on. If you feel alone, and there's a parallel process even with substance abuse. If you feel like you're not going to be accepted or fit in or get help that you need because you have a disease the disease of addiction or HIV and AIDS. There's discrimination against clients and patients who do not comply with traditional medical models of treatment. In many cultures, in some cultures, people believe in roots or organic medication, herbs. And so we need to be accepting of those belief systems too. There are people who are suspicious of traditional medical models of treatment. Hopefully we can influence those individuals to do a combination of both, respecting the fact that they believe in the herbal approach to treatment and other healthy lifestyles, but that you know, we have evidence that the traditional medical models can also be very effective. And it's not uncommon for those who have addictions to be deprived of needed treatment due to these issues, all of the issues that we just discussed. All right, psychological impact within the substance abuser. So treatment failures due to health issues. Clearly, I think we've all seen situations where if someone's health is poor or they need to be stabilized, that will impact their ability to do well in treatment. If people are depressed, again, that will definitely have an impact on the successful outcome of any treatment intervention. Clearly, being HIV positive can be a relapse trigger, depending on how people are coping with the disease and the ups and downs. Maybe once in a while you'll have a patient who is doing well and then maybe get an opportunistic infection and feel depressed about that, and that may result in being a relapse trigger. Being rejected in some way because of their disease may also be a relapse trigger. So we want to look out for those psychological components. There are patients that will have a fatalistic attitude about having HIV, especially if they are not clear exactly when and how they got infected, or they feel as if, you know, having HIV is an injustice, and sometimes they want to hurt other people based on that feeling, or continue to hurt themselves by continuing to use drugs. Why should I bother to recover? I have this disease and I'm going to die anyway. I might as well continue my drug use. Clearly, you know, how I feel about myself will affect the quality of the recovery of the patient. So how the patient views their life will also impact the quality of the recovery that they can have. If they are have family conflicts, in addition to the conflicts that might result from their substance abuse, the HIV and AIDS status can definitely increase that conflict. So we want to be clear that we help patients to negotiate the issue with their families if that's possible. Patients may also feel isolated, again, from family and friends. And there's clearly, in some cases, and I would say in extreme cases, suicide potential for people living with HIV and AIDS. Treatment considerations. Counselors and other agency staff, knowledge base. Extremely important. When I do this in a face-to-face training, I always take a little poll asking how much people think they know about HIV and HIV transmission, and what's their comfortability in working with the population. So the staff and the agency's approach to it is definitely a treatment consideration. Rational versus irrational fears. Can I get HIV if I'm a counselor and I allow a patient with HIV to use my phone? Well, the answer to that is no. So that would be an irrational fear. If we understand the routes of transmission, that should help us to take a more rational approach. But again, being human, we may have some irrational fears, and those need to be dealt with in order for us to provide effective services to our patients. Ability to collaborate with medical professionals, such as infectious disease doctors, is key. we're counselors, therapists, social workers, and I think, there's a wonderful saying that the adolescents use today, and it's called staying in your lane. And I like that because I think although we may be knowledgeable, and some of us may even have that background as professionals, I think our role is really not to talk so much about the medical side of it, but the patient's feelings about the medical side. Because interestingly enough, medical practitioners don't talk about the feeling side of it when they're explaining to them that you've built tolerance to this particular medication, so it's no longer working effectively. The doctor's not going to have an individual session with that patient exploring how they feel about that news. So that's where we come in at, and that should be our main focus. Although I think it is important for us to have a basic 101 knowledge of the medical information so that we can have a discussion about it or understand what the patient is sharing with us. Bias, I always, in a face-to-face training, ask people, is anybody in this room that doesn't have any biases? Well, if somebody doesn't raise their hand, I get concerned because I think we all come to this work with our own prejudices and biases. But again, we need to check them at the door of our work environments, put them in a little paper bag with our name on it, and go in and be non-judgmental with the population that we serve. Clearly, one of the treatment considerations, harm reduction as a model of treatment is still, somewhat controversial with substance abuse agencies. Abstinence-based trained clinicians tend to struggle with the idea of reducing the harm because it would require you to really meet a patient where they're at. And if the patient says, well, I drink 6 glasses of vodka per night, the harm reduction approach would say, can you reduce those 6 to 3, and then let's talk about how that makes you feel. Naturally, the goal is to get down to none and to abstain from using alcohol, but it's a process of allowing people to reduce the harm. Or don't drink and drive. And I think it's a difficult approach because it almost sounds like we're condoning the drinking, and that's not what harm reduction is doing. Harm reduction is to, until the person can actually change the behavior, to do things that reduce the harm. So if you have someone who is a sex worker, for instance, until they're really able to stop being a sex worker, one of the things we want to do is ensure that they understand how to protect themselves as they continue to do sex work, using condoms, not coming in contact with body fluids, those types of things. So that would be a consideration depending on the setting in which you work. Inclusion in relapse prevention and treatment planning, clearly a consideration that should be in every relapse prevention plan for someone who's living with HIV and AIDS is their health and how they feel about it. Because there is the potential, if I'm frightened, fearful, anxious about my health status and whether or not I'm going to live or die, that may impact my ability to remain abstinent from all mood-altering substances. All right, so we continue with the treatment considerations. What's the staff's comfort level talking about safer sex practices and being knowledgeable about options? I think most of us did not get our sex education at home. It is one of those subjects that is so personal that sometimes, we get a little embarrassed about talking about it. But I think because HIV is transmitted primarily through unsafe sex practices, clinicians need to be extremely comfortable and knowledgeable about safer sex practices and being able to communicate that to patients, give them options that would provide them the opportunity to still be sexual beings, but to practice safer sex. And from a prevention model, clearly we need to teach people who are not infected, who have substance abuse problems, to remain HIV negative by practicing safer sex at all times and what those options are. And there are many out there, clearly. One example is, Jocelyn Elders, who was the Surgeon General during the Clinton administration, got herself in a little trouble for talking about masturbation as a safer sex practice, mutual masturbation, that is. And in the media, her statement was naturally taken a little bit out of context. But clearly, mutual masturbation is a safer sex practice. And so we need to present that as an option. And for some of our patients, that may be a really good one. So that's just one example of being able to have the ability to communicate that. Confidentiality, clearly there was a question about that. I'm sure all of us are familiar with the HIPAA laws. And so talking about a patient's health status, not only HIV, but any information about the patient, we cannot do that without a signed consent form. Even to make referrals, you know that you also need to have a consent form. And actually, sharing HIV/AIDS information should be on a needs-to-know basis outside of the team in your particular work setting. For instance, if a patient faints in your facility, and when the EMS people arrive, what you need to be able to tell them is what medications they're on. All healthcare professionals understand the use of universal precautions. And in that moment, you are not obligated to tell them that the person is HIV positive. That would be a breach of confidentiality because they don't need to know that to save that person's life. Sensitivity, clearly, if we are insensitive with this population, that will affect how well they do in treatment. We need to be cognizant of nutritional needs and schedule our interventions around that. Some of our patients will be taking medications that require that they eat before they take it, and they must take it at certain times. And sometimes those times will conflict with their treatment schedule. So be mindful that there may become a need for you to have snacks or other things available for patients who have either specific medication, food connection needs, or specific nutritional needs to maintain their health. What are the staff and the client's feelings about the disease? So if we have a staff person who is insensitive and has limited knowledge about HIV, and a client who's feeling anxious about it, clearly that's not going to be a really strong therapeutic alliance. The staff member probably will not be very effective in helping that particular patient as a result of their feelings and how the client is feeling. Disclosure policies, as we said earlier, we are not allowed to give out any information about a patient's HIV status unless we have a signed consent to do so. Christine, are there any questions?
No, we actually don't have any yet.
Okay, great. All right.
Thanks for checking.
All right. Intervention considerations. Clearly, we need to do thorough assessments and identification of issues that affect the individual's responses to treatment. This will give the council a better understanding of the distress or the level of distress felt by our patients and help them to introduce healthier coping alternatives. So clearly, one of the things that we want to assess, if the person even knows this, how they became infected, what's their lifestyle? Are they gay, straight? Are they married? Are they in a relationship, not in a relationship? What's their personality style? And what's their cultural background? So most assessments capture this information, but as it relates to HIV and AIDS, we really want to zero in and connect the dots in terms of an infected individual, how they live, what their relationship is, and what their personality style is, and definitely their cultural background, because their cultural belief systems may also affect their ability to have successful treatment outcomes or respond well to traditional intervention. So let's look at some of the patient profiles First is the worried well. This individual patient experiences guilt about their sexual behaviors when under the influence of drugs, but has not yet been tested for HIV due to the fear. So oftentimes people may have some understanding that they are engaging in high-risk behavior when they're under the influence, and we know that it's not just IV drug use, because IV drug use definitely is a route of transmission. But when you're under the influence of any drug, you're more apt to let your guard down, be less inhibited, and engage in behaviors that you would not engage in if you were not under the influence of a drug. Undiagnosed, confirmation. So I suspect, this particular patient suspects that I'm positive based on my sexual and drug abuse history, but then fearful of being tested because I don't want to know the truth. I may die, so I'll just continue to get high. So when you encounter patients like this, or people who are coming into treatment for substance abuse, one of the things that you want to be able to work with them around is the benefit of knowing one's health status, whatever that is. And in this case, it would be HIV, so that because there is treatment today, it is in their best interest to be tested and to know what their diagnosis is. All right, so it looks like we're ready for polling question 3.
Okay, this is the perinatal one.
Mm-hmm.
Okay, I'll launch this poll then. Perinatal HIV transmission is the most common route of HIV infection in children. Please answer whether you think this is true or false. And while we're getting those responses, I do have a question for you. A patient has an undetectable viral load and considers themselves cured of HIV. How should we respond to this? The patient uses Magic Johnson as an example.
Yes, that example comes up often. And again, I think we have to understand that a person living with this disease is looking at ways to kind of deal with it in a way that's less stressful for them. So if I equate having an undetectable viral load with being free of the disease, that keeps me comfortable. I'm better able to cope with the reality of being HIV positive. The fact of the matter is, though, is that an undetectable viral load is a good thing. It does not mean that the person is free of the disease. And that's always how I address it. That having an undetectable viral load is great, because that means that you're still very healthy. And if you're on medications, those medications are working. Those are the indicators for an undetectable viral load. Magic Johnson is not cured. His viral load is undetectable, but he still has the disease. And that just means that the disease is not progressing that quickly. In other people, they do have a detectable viral load and a low T cell count. So when a patient says, my viral load is undetectable and I think I'm cured, I would just explain the kind of facts and also encourage them to have conversations with their medical providers about exactly what an undetectable viral load really means. Does that mean you're disease-free, the disease is gone, or does it mean that you're still very healthy and that your medication is working? So you put the positive slant on it, because it is a positive thing to have an undetectable viral load, but you also want them to be clear that that doesn't mean that they do not have the disease, and most importantly, because if I believe the disease is gone, I may engage in unprotected sex because I believe I can infect people. So that would be another point I would make. Even though your viral load is undetectable, if you engage in unprotected sexual activity, you can infect other people.
Okay. Okay, thank you. I'm going to close this poll now, and we'll share the results with everybody. Perinatal HIV transmission is the most common route of an HIV infection in children. 70% of the respondents said that that is true, and 30% said it is not true.
Wow, okay.
Yeah, so that's really split, and I'm going to close this now, and you can respond.
Okay. Remember that early on we talked a little bit about perinatal transmission, and that I've kind of gone over the fact that there are three routes of transmission. One is in uterine, right, while the mom is pregnant and carrying the child. The second is in the actual birthing process, as the baby is passing through the birthing canal, coming in contact, if it's a very traumatic birth where the baby comes in contact with the mother's blood and fluids. And then finally, if an infant is taken home who's not HIV positive but is breastfed. So in actuality, those are the three options in terms of an infant being infected. And I'm not sure if we have exact data on, out of those three options, which is most often the cause of transmission.
Okay, thanks. Do you want to go on, or do you want a couple more questions?
Are there questions?
Yes.
Oh, okay. Go ahead.
Okay. First of all, somebody wants you to clarify the specific laws and consents that apply regarding HIPAA, 42 CFR, and New York state laws. Now, this is going out to a lot of people all over the country, so please talk about the national laws and then maybe where people can find specific laws that might apply to their state.
At the end of the webinar, there's a slide that's going to give websites so when you, where they can find out information in their specific state. So when you send out the PowerPoint presentation, they will have that information. I was made aware that there would be people on the webinar from all over the country. But in terms of New York State, again, the only law on the book, the only healthcare professional that is able to disclose HIV status without the patient's permission is a physician. And that's called the partner notification law. As a counselor, again, in the same way that we would not share information that the patient did not give us permission to about their substance abuse treatment, the frequency of their use, how they use drugs, we would need to have, and you know, HIPAA has made all of those things much more specific. I mean, what's the need of the disclosure of the information? How will it be used? How long is the consent in effect for? So in New York State, there are, to make referrals, we need to have the patient's permission to give that medical information if, in fact, the referral requires that they know about the person's HIV status. Because we may be referring a patient somewhere where that's not something they need to know.
Okay. And the next one is, if it's detectable, how do you safeguard, especially from your children, and can the information be accessible to the schools? And are the children listed as, can the children then be labeled as unsafe?
Oh, if a child is HIV positive is the question?
Well,
if
a parent is has detectable HIV, how can they safeguard from their children? And can the school get information on your on the parent's status?
No, not in New York State. And the question I would ask is, why would the school need to know about the parent's status? Unless they're having intimate contact or coming in contact with that parent's body fluid, there would be no need for them to have that information. As a matter of fact, it would probably definitely cause more problems, because then the child would be stigmatized. I think responsible people living with HIV take precautions. And again, there are very clear ways to get this disease. You don't get it by touching the doorknob of someone who has HIV who touched the doorknob right before you. There needs to be intimate contact or the sharing of body fluid. I'm not sure if many people probably remember the Wright case. I mean, there's a fund actually named after him here in New York, actually. Oh, no, I think it actually is a federal fund, the Wright Fund. And Wright was a hemophiliac. And if you remember at the time in school when it was put out that he was HIV infected as a result of getting a blood transfusion, I mean, it was very difficult. There was a lot of pushback in his community. It made it really awkward for him to attend school. I mean, and eventually he passed away from the disease. But I think what we learned about that from a confidentiality approach is that it should be on a need to know. And because of universal precautions, there really is less of a need to disclose, because we all do need to be practicing that.
Mm-hmm. Okay. And the last question. Okay. Let's see here. I'm sorry. If you have undetectable viral load, does that mean you are less infectious? Yes or no?
That's a good question, and here's the. There are variables that would impact that. I think that the rule of thumb is that yes, if your viral load is lower, you are less contagious, I guess is what the question is asking. You still have the ability, though, to infect people. And remember that there are different strains of the virus, too, as well. So I think we would have to factor in, when we talk about viral load just means you're healthier, you're still fairly healthy, your immune system is functioning fairly well because you're on medication. That doesn't mean that lessens, or I would want to send the message that because someone has an undetectable viral load, they're less likely to infect someone else. Because I don't think we know that conclusively. I think you can still infect other people whether you have because you still have the virus. It's just that you're healthier because you're on medication and maybe doing other things that help you to keep your health stable. But you still can infect other people with an undetected viral load.
Okay, that's it for the questions. Thank you.
You're welcome. All right, we're going to continue with the client profile, dealing with the HIV positive diagnosis, issues that come up for this group of particular clients or patients. Self-disclosure is a big issue, especially when someone is first diagnosed. So I have the question there, who do I tell? I worked in the VA hospital for many years on the substance abuse unit, and oftentimes patients opted to be tested while they were there, and they would get the results while they were in either detox or rehab in one of the treatment settings. And you see a lot of different reactions to that news. Some people were not surprised when their test came back positive. They would say something like, you know, I kind of felt like I was. I've had some indications, some symptoms, and I know that I've engaged in a lot of the high-risk behaviors that can result in you becoming infected. Others will say something like, you know what, I think the test is wrong. I want to get a second opinion. And then there's a lot in the middle. But oftentimes, what I encourage patients to do is not to tell anybody right away until they have a moment to kind of digest the diagnosis for themselves. That can be a process as they're moving forward, that they come first, that they need to take care of themselves, that they need to address their substance abuse issue, that they need to get HIV education, if they're going to take medication, get all those things put in place. And then, as they're feeling a little bit more comfortable and secure about the diagnosis, and, you know, then it might be a time to decide to look at who in my family do I need to tell, what friends do I need to tell. But I don't think that they need to feel like they have to run out and tell everyone that they've just found out that they're HIV positive. So self-disclosure is a real issue for people. Do I keep it a secret? You know, will people fear me or shun me because now I have this disease? So who do I tell is a real issue. Compliance with medical treatment. Well, we know in this field, when you look at the stages of change, patients may be in different stages with different issues or clinical concerns or problems in their life. So for instance, in terms of their substance abuse, once they get the HIV diagnosis, they may have already been in maintenance with that and doing well, but it might take them some time to get to that stage of change with the HIV treatment. So we want to be mindful of that and use the same process. They don't have to reinvent the wheel. Whatever they were doing to get into maintenance for their substance abuse, we can apply that to them getting into maintenance and being compliant with the medical treatment for their HIV. But it's common for them to, or they may be in compliance with their medication in terms of their HIV and still struggling with some sporadic drug use. So again, you also want to look at where they're at in terms of each issue. A preoccupation with maintaining good health and the ability to function. Well, clearly, I think anybody with a disease that has the potential to be debilitating or, you know, terminal, there is or there can be a preoccupation with maintaining good health and, you know, the ability to be self-sufficient, cook for myself, care for myself, you know, do my own laundry, the things that some of us begin to take for granted. And so when you identify that in this group, I think the important thing to do is to help them to see what level they are functioning at, and that the disease has not necessarily impacted them in a way where they're not able to function at their level. I mean, even aging, for instance, affects our functioning. And so I think we have to help them to look at the reality of their ability to function and maintain what might be considered their stable health with living with HIV. Changing one's sexual practices and negotiating safer sex behaviors. This can be difficult as well, simply because negotiating requires some level of self-disclosure. Talking about the need to practice safe sex may result in people asking, especially in some cultures, well, why do we need to do that? There's nothing wrong with me. Is there anything wrong with you? But clearly, we do want to arm our patients with the ability to say, you know, it's important. It's not an indictment or a judgment. It's just important to practice safer sex. But negotiating that for some people, oftentimes for women, can be very difficult in that there is the question that you're raising by even bringing that up. Why do we need to practice safer sex? So that impacts one's ability to change sexual practices if they can't negotiate safer sex behaviors. Coping with the development of symptoms. Am I getting sicker? And will I die now? And again, I think with any disease where you have the potential for relapse or the return of symptoms, this can be a real anxiety-provoking concern for patients. And so when you're working with patients that have HIV and know their status, when they get sick, I think if they get sick or if they need a change in medication, I think you really need to focus on, or we really need to focus on, how they're feeling about that, what their fears are. And then again, collaborating with the medical staff to find out what the reality is. Is the patient going to get better? Are they going to have to do some things differently now? Maybe it's mean a hospitalization. And the thing that we really want to be focused on is that the person somehow accepts that they don't need to use drugs or return to drug use to deal with the development of symptoms. As a matter of fact, doing that would probably have an adverse effect on the symptoms, because if we continue to use drugs, and you share this with patients, if they continue to use drugs, that also impacts and compromises the immune system. Even if you have a healthy immune system, drug use does that to your immune system. So when people develop symptoms or go into the hospital, when they return to treatment, I think it's important to encourage them to really talk about and give them the option or permission to really talk about their fears about death and dying. Or, again, just getting sicker and not be able to take care of themselves. All right, so we'll look at special populations now. We'll start with gay men. HIV and AIDS has been, unfortunately, and continues to be associated with gay men exclusively. But as we all know, again, this is a disease of the behaviors, and you can be heterosexual, bisexual, gay, black, white, short, tall, rich, or poor. If you engage in high-risk behaviors, you can get this disease. Yet we know that it is not. And in the beginning, in the early days, it was actually called at one time the gay disease, as we thought early on. So anybody on the planet can get HIV today if they engage in high-risk behaviors. It is important to take into consideration that most gay men have lost friends or lovers or partners to the disease, and other gay men that are currently infected. So in the gay community, they have been, I don't want to say the hardest hit, but the most affected because the disease was identified with them. Like it's not uncommon, I think, for most of us. I often hear colleagues and friends, we all know someone, or we have a family member that uses drugs. So it's not foreign to us. So this is something you want to take into consideration, too, because I think it can intensify the anxiety, because they've been much closer to the disease in terms of a personal connection. The grief and loss gay men feel and share is profound. I wouldn't minimize that. It must be a treatment consideration when working with this patient population. And also just the association that still continues today, that automatically there's an assumption that if you're a gay male, you are automatically means you are HIV positive. And that clearly is not the case. There are gay men who are not infected with HIV, and one of the reasons for that is that they do engage in prevention and practice safer sex. But there is the association that if you're a gay man, you are, or you must be, or it's assumed that you are HIV positive. So polling question number 4. Christine?
Yep.
Okay.
Okay, I will launch this poll now. Parents of adolescents who test positive for HIV should automatically be told of their child's status. Do you agree with this statement or don't agree with this statement? And I have one question that's been asked, so we can do that while people are filling out the poll. And I think this goes back to the previous question about a parent who might be HIV positive and being around their children. they're talking about, would there be an issue with sharing a cup that has saliva and it is exchanged? And then they're worried that a school that has children's musicals, and what if the child has an undetectable form of HIV and they're attending school?
Okay. Well, the first question about the cup, I'll start with that. One of the things that we do have information on is that HIV does not live outside of the body. So the question is, though, how long does it die in a fluid that, let's say, is outside of the body, like saliva? So saliva on a cup, and actually, if it was a slide early on about saliva, the detection of HIV in saliva, there was a formula once. I'm trying to remember exactly how it goes, but there was a formula once that said you would need the equivalent of something like, I don't know, 10 gallons of infected saliva, and actually, I guess, have to be taking it in order to get infected. So in terms of the saliva on the cup, there's no risk there in that the saliva is outside of the person's body, right? It's come in contact with air. So there really isn't a danger of transmission from the saliva on the cup. But again, see, these are good questions because these are questions that patients will have. And so that's why being armed with factual information is really key. Now, about the school kids. One of the, I think the major concerns is that kids don't always play safely. And I think that's what this question is getting at, that if a kid has a cold, more than likely the other kids in the class catch the cold. But we also understand how the common cold, the flu, TB, how those things are transmitted. It's different with HIV and AIDS. So when we have to talk about the contact with a sore. And in the public school system today, teachers are also educated on practicing universal precautions. So for instance, if a child falls down and skins their knee and is bleeding, the teacher should not, or should be aware that she should not take care of that wound without having some gloves on or some sort of protection, not coming in direct contact with the body fluid. So that's what we have to rely on today in terms of that. And again, unless the behavior, there's direct contact with the child, and it's a trade-off. I think we have to kind of weigh what would it be like for a child in school if it was well known that that child had HIV, versus people not knowing and practicing universal precautions.
Okay, thanks. I have the results of the poll now. I'll close it and show the results. And I also have 2 comments that people made regarding their vote, so to speak.
Mm-hmm.
For parents of adolescents who test positive for HIV should automatically be told of their child's status, 61% agree and 39% disagree. And there are 2 comments that were made by people who participated. The first is, this question is hard to answer. It could go both ways. A child should get support from the parent, and the child should also have their privacy too. And the other comment is, do you think because adolescents' frontal lobe in their brain is not fully developed that they might not make the most appropriate decision as far as treatment is concerned, therefore allowing parents to make a more appropriate decision for them?
Okay, great. And with the answer to the second comment about the brain development, we're going to be talking about that. But clearly that is an issue when we talk about age-appropriate behavior for adolescents, and that's coming up on one of the slides about, yes, that their brains and other internal organs are still growing, and it does affect their decision-making. It's common for adolescents to engage in risky behavior. It's a part of being adolescent. So we're going to talk about that in just a few minutes. I agree with the first comment that this is, and these questions actually are designed more for discussion, and then we have to look at, again, the individual state laws. For instance, in the state of New York, an adolescent female does not have to have her parents' permission to seek treatment at Planned Parenthood. That can be kept confidential. And the same reasons apply here, in that it would be great if we were sure that what would happen if an adolescent revealed their status to their parent is that they would get support. But what may happen in extreme cases is they may be harmed, or they may be shunned, thrown out of the home, or if they remain in the home, they may be abused, isolated in the home. So the adolescent at that point should be able to make, receive services, but I would say we have to weigh whether or not there's a real benefit in them, the parents being notified, or can the adolescent's health be managed without the parents' involvement. So it is one of those questions that's kind of up for debate. But in terms of the law, there isn't a requirement that the parents are informed.
Okay, thank you. That's it for the question.
All right, great. So let's look at the special populations, and we'll get back to that adolescent issue in a moment. When we talk about women with children, I think one of the issues is if the parent is HIV positive, and let's say has children who are, school age, adolescents, and the parent finds out that she's HIV positive, how do I tell my children? Or do I tell my children of my HIV positive status? We're all familiar with family secrets, and people, agree and disagree on this. How does the family impact it? By knowing the mom's status. I mean, I'm sure we've all known cases where a parent was terminally ill and did not tell her children because she didn't want them to worry. Could have been cancer or something else. And they don't find out until the mother passes away that she had been ill for a long time, or they find out when she starts having symptoms. So again, I think this depends on that particular individual, what the relationship was, and weighing with the patient the pros and cons of sharing their health status with their children. One of the things that I do think is really important, whether the parent decides to disclose to their children, is the importance of planning for the children's care in the event that the patient can no longer care for them or die. There should be some sort of provision put in place so that the parent actually will feel more confident knowing that her children will be cared for in the event that she gets really ill or in the event of her death. When a mother is infected and has a child that is also infected, I think when you have children that are born with any kind of disability, it is not uncommon for the mother to feel some guilt, even if, in fact, she didn't do anything wrong. She did everything right. She had good prenatal care. She didn't use drugs. But if we're talking about a woman who has been a substance abuser, is infected with HIV, and feels as, she infected her child, that intensifies her guilt and shame about the disease. And so with those women, you really want to work hard at addressing the issue of intent and how having a disease sometimes or oftentimes impacts our ability to make the best or the healthiest decisions for ourselves. So I would want to help that patient to not allow those feelings to result in her relapsing or returning to drug use. And that's the guilt and shame connected to all of the above. And again, the real relapse prevention, and it does affect the female patient's ability to be compliant in treatment if she's feeling this tremendous guilt and shame about her having the disease and maybe having a child that has the disease. So those would be the treatment considerations with this particular population. When we talk about seniors and older adults, there's been a steady increase in the number of HIV/AIDS cases in adults age 50 and plus, and that those data comes from the CDC. In 2004, there were 21.5% of the older adults, 50 or older, were living with HIV. In 2007, the percentage of persons 50 and over living with HIV and AIDS increased to 27.4%. And again, that's from the CDC. So we can see that over a 3-year period, there was, I wouldn't say significant, but an increase in cases in this population. And one of the causal factors is, and we're going to talk about this in a few minutes, is how we view seniors. And I think we sometimes take the same position that we do with some substance abuse. We give them permission. Well, if they're, we can meet the criteria for being alcoholics, we might call them teetotalers and say, oh, it's not a big deal. I mean, she or he is 60 years old. They've worked all their life. They should be entitled to drink. And so we have to look at our attitudes about this population in terms of lowering some of these numbers. The National Institute on Aging reports that nearly 1/4 of all people with HIV/AIDS in the United States are 50 years or older. There's a couple of articles recently written on grandmothers with HIV. African Americans and Hispanic persons in this age group, from baby boomers, account for half, 52% of the overall older adult cases. So when we talk about senior adults, there are stereotypes about this population, such as that they are less likely to be sexually active or use drugs. Well, let me tell you that I would say right now in the agency I work in, we may have about 40 some odd clients who would be in this age group, and I know, I kind of looked at this, 26 of the 40 in this age group are HIV positive. And the reason for that is that older adults continue to have sex, and from this generation, HIV wasn't a consideration then. Actually protecting yourself from other STDs wasn't even a big consideration in many cultures or populations, because you could go and get medication and be cured from it when we talk about things like syphilis and gonorrhea. And so in this particular age group, we tend to believe that little old ladies and little old men are not having sex. Well, they are. And so we need to develop prevention material that directly speaks to them and also educates professionals in the field to ask those questions. We had a situation once where a 59-year-old woman during her assessment wasn't asked about safe for sex because the professional just assumed that she was too old. And when we confronted the intake specialist, she said, well, she reminded me of my grandmother. I didn't feel comfortable asking her about her sexual practices. Come on, she's a 59-year-old woman. 59-year-old women and 59-year-old men continue to have sex. Safer sex practices, such as the use of condoms, is not a concept this generation connects to. Since their thinking is that in this instance, in this age group, pregnancy is no longer an issue. And again, STDs can be cured with antibiotics. Older adults are less likely to talk about sex due to embarrassment. Again, I brought up earlier about most of us didn't get our sex education at home. It just isn't something I think as a society we're totally comfortable talking about. I mean, I know some people did, but most of us get that from our peers, or we hear things, we read things, seldom are people comfortable really talking about it, and clearly in an academic way. I mean, the birds and the bees doesn't really explain it, I guess, in the most productive of ways. There are a few prevention initiatives that target this population. We found that out with the MSN population as well, because a lot of the early prevention information was geared more towards the gay community. And so if you don't identify as gay or you're not an IV drug user, you're less apt to pay attention to literature, prevention information, or initiatives because you don't feel like you fit that particular group. So we do need to talk to our older patients, 50 plus, about HIV transmission, and we do need to ask those questions at assessment whether or not you're sexually active. Due to health issues that come with aging, there is concern about whether or not an older person can tolerate the very powerful HIV medication and the possible interaction with the other medications they're on for some of their other health issues, such as, the very common ones, diabetes, hypertension. So we just want to be clear that, being treated for HIV is going to be something that's working well with the treatments for their other medical issues as well. All right, any questions, Christine?
Yes, I do have a couple. Let's see. If parents are not told of HIV diagnosis of a child and the child gets treatment, insurance claims could come through that the parents will see, and that could cause some issues. How would you handle this?
Okay, that's a really good question. And in the state of New York, we have an insurance specifically that would provide and address this issue. It's called ADAP. And so the adolescent would not be required to use their parents' insurance coverage because ADAP would pay only for HIV treatment. That would be it. And the parents would not have access to that information. They would continue to get their primary care, see their primary care physicians or, a specialist or whatever, the dentist, under their parents' coverage. But for their HIV medications, if they opted to go on medication, they would be eligible for ADAP. Now, that's in New York State, so I'm not speaking for throughout the United States, but in New York State, we do have that as an insurance specifically to address the needs of the HIV population who are either underinsured, have no insurance, because these medications are life-saving.
Right. Okay. And then there's a comment that the increase in seniors, I guess, with HIV, they feel is related to the better treatment and being able to service longer. So I guess they're able to be on the medications longer and are doing better because of that.
Yes, definitely. Well, I think we can, just look at how life has been extended overall. So even someone who may have contracted HIV as a senior still has an opportunity just because of medical technology in general, in addition to the HIV medication, to live longer with the disease.
Yes.
And if they're living longer and still not practicing safer sex, I mean, we haven't done real research on it, but one of the things that we found out with infected women in that age group is that their sex partners also engage in high-risk behaviors with women in the sex trade that may infect them and then may infect their contemporaries. With sexual activity outside, even people living in assisted living or nursing homes. They get their SSI checks and they go out with prostitutes and have unsafe sex and not aware that they're
Thank you.
Okay. So according to the CDC in 2010 data, half of all new HIV infection cases overall are believed to occur in people under age 25, which is kind of, late adolescence. New cases from heterosexual contact are the highest in this population. So not from gay and lesbian teenagers, but in heterosexual contact. This may be due to the early identified populations such as gay males and IV drug users. So we don't see as many IV drug users in this population as we do in adults, so therefore that limits that from being one of the routes of transmission. And again, because of the stigma and the connection between being gay and HIV, many heterosexual adolescents don't feel that when they hear that information that they need to follow the same rules in terms of having safer sex. Adolescence is a time of storm and stress, as you know, if you have one in your home, directly related to the psychological, emotional, and physical changes that occur during puberty. And I think one of the comments was about the brain still growing. This period of life, it's a period of lifespan development. And so, yes, the brain and other internal organs are still growing, and that does impact adolescent behavior. And here we see it. We talk about age-appropriate behaviors and attitudes such as experimentation. Adolescents are famous for that, and risk-taking. That impacts prevention efforts and also responses to treatment. So they are a tough group to work with as a result. Core aspects of identity. They're developing their identity, and so it's very hard to influence that when you don't have a total, clear sense of self yet, or a level of self-esteem. So finding out who I am, working on that process at the same time as trying to incorporate practicing safer sex, preventive measures is a difficult task because though you need to have the ability to reason and think about it from a more adult perspective. Drug use affects meeting developmental milestones. We know that. We all know that at the point that people start using drugs, the developmental milestones are affected by that. So if we have a substance abusing adolescent whose developmental milestones are being affected, in addition to all these other variables about trying to find out my own identity, going through puberty, and then finding out that I'm also infected with HIV, as it says here, dealing with a stigmatized disease compounds the already turbulent process of adolescence. So treatment compliance and parental support, if possible, because that's always questionable, really does affect treatment outcomes. So some practical suggestions for providing competent treatment. Counselors and clinicians need to do what I call, and I think we are all familiar with, self-monitoring around this issue. If you have some homophobia, or this isn't up there, but it should be up there, if you have homophobia or AIDS phobia, HIV/AIDS phobia, seek some supervision about it. Don't label patients that have HIV in a personal way, and what I mean by that is you may not verbalize the label, but you've already decided and made up in your mind that, as in the next prompt, that it's going to be harder for this person to get recovery because there's somebody living with AIDS. I think that if you start off coming from that place, you're more apt to maybe even give up on that patient. Get training on the disease whenever indicated. Strict adherence to confidentiality as it relates to HIPAA laws, and we've talked about that this afternoon already. Integrate and collaborate with medical professionals, clergy. That can be a real important resource in one of our patients' lives. And more the churches are getting involved with HIV prevention and treatment. There's actually an HIV/AIDS ministry in New York State. And many churches now are taking the approach that, although clearly religion has its own kind of views of this disease and how it's contracted, but that there needs to be compassion for the people who are living with it. looking for other community resources, and definitely if we have family collaterals, that's great, but that may not always be the case. So you want patients to develop their own support network, as we would in recovery. Some more suggestions. Newly diagnosed patients will benefit from a counseling approach on acceptance of having and living with a chronic, possibly terminal disease. In the early days, what we were doing is putting people who were newly diagnosed in groups with people who were at end-stage AIDS. And in other areas, for instance, if a woman just found out today that she has breast cancer, she shouldn't be in a group with women who have already had a double mastectomy and been managing that and how they feel about it emotionally for years. They don't have the same issues. And so newly diagnosed patients need to be approached and addressed from that perspective. They've just found out some information that can have a real adverse effect on their drug use. So you really want to talk about the newly diagnosed differently than someone who's been living and managing the disease for longer. So patients that have been living with a chronic illness will need to focus on accepting multiple medications as a possibility for the rest of their lives, taken on a daily basis. Because once a patient is placed on HIV medication, they do have to take it for the rest of their lives. The medication may change, but once you start taking the medication, it is strongly, patients are strongly encouraged to never stop and to take their medication as prescribed and on time, because that's what will keep them healthy. As a matter of fact, there are indicators that suggest that when people stop taking the medication, they can get sick rather quickly. So in both cases, you advocating for that and providing case management interventions, making sure that all of the services that a patient may need or require are being met. So recovery as a lifestyle when living with HIV and AIDS, I think this is such a great slide. Get plenty of rest, eat a healthy diet, reduce stress in one's life whenever possible, abstain from drug and alcohol use, protect self and intimate partners, sex partners, spirituality, having a support network, some form of exercise, doesn't necessarily mean the gym, but some form of exercise. Have goals. If you believe in the mind and body connection, a positive attitude, positive thinking can help. And having goals makes people feel alive, something to reach for. Medical and substance abuse treatment compliance, you definitely want them to buy into that and to, maintain a quality of life. And then factual current information. Encourage patients, as we do with recovery information, to really stay current on how to maintain their health in terms of their HIV status. So when you look at this, this kind of laundry list of recovery as a lifestyle, I think it's safe to say that everybody should live as if they're HIV positive, because those are great. Now, I'll just go back for a minute. I think those are great prescriptions for life for anybody, whether you're HIV positive or not. I'd like to get plenty of rest. I'd like to eat a healthy diet. I don't. Definitely we want to reduce stress whenever possible. There's no such thing as a stress-free life, but clearly we want, for someone with HIV, we want to reduce the stress as much as possible, abstaining from drugs and alcohol. I mean, again, this is a great prescription for living a healthy lifestyle, both in recovery and for someone who's HIV positive. So when I say this, sometimes people get kind of this strange look in their face. Why should everybody live as if they're HIV positive? Well, the answer is this. There'll be a reduction in new cases of infection. If we all protect ourselves and encourage our patients to do the same, we should see a reduction in new cases, right? Clearly, extending life, living longer with the disease. If the patient is already HIV positive, then living the way we looked at with that laundry list, that will extend their life. Have an improved quality of life. Again, back to having goals, the exercising, having some spirituality. Removing the stigma. So being clear that HIV, again, is considered today a chronic illness like any other illness like diabetes. People are living with it, and people are living for extended periods of time if they take care of themselves. We definitely would like to see greater sensitivity. So if I'm taking the same precautions as I'm sharing with my patients in terms of being responsible, then I think that does kind of encourage and foster greater sensitivity, and that will all impact treatment effectiveness. So this is the slide that I made reference to earlier about where you can get information. This information is specifically for New York, but I would say, I know we have 311 here in New York, but contact any of your Google. You might want to just Google for whatever state you're in, HIV and AIDS services or information, and then that hopefully that site will direct you to some resources that you can use for your particular patient. Christine, I know we're over time, well over time. Are there any other questions?
No, I think you've taken care of it all.
Oh, okay.
Yeah, thank you so much. It was very, very informative. I think we've answered everybody's questions, and I will be following up with an email by the end of the day today that will include the PowerPoints, that will include the CE order forms, certificate of attendance, and very important, a link to the evaluation for this webinar that we hope everybody will participate in. A couple people have shared their login information, which is fine, except their name shows up each time somebody else uses it. So if you will please forward the email to the other people who were on this, and if they would let me know that they were on this, I want to be sure to be able to recognize everybody for the time they put in. So at this time, we will finish the webinar, and again, thank you all for participating.